Howdy, my name is Frankie Jackson, pronouns are they, them. I'm the coordinator of the LGBTQ plus Pride Center here at Texas A&M University. I want to start off by thanking our panelists for taking their time to come to speak with us tonight. We have Dr. Allison Pittman from Texas A&M's College of Nursing, DJ, Dr. DJ from the Health and Education Director of Clinical Simulation for the University of Houston's College of Medicine. We really appreciate you all coming and talking about health disparities. We're going to start off the panel with some introductions. We like to let them tell us about themselves. Allison is going to go over health disparities with us, so we all have a grounded knowledge of what we're talking about with the topic. And then we'll go into some pre-scripted questions, and then we will have a Q&A. Folks can submit questions over Facebook Live to us, or if you're here in the webinar, you can type them in and ask them to the panelists directly. So that's a pretty exciting new feature. And with that, we'll ask Allison to start us off with introductions.
Howdy, I hope you all can hear me okay. I'm Allison Pittman. I'm a clinical assistant professor at Texas A&M College of Nursing. My pronouns are she, hers. And I am really focusing a lot of my research on patient care on LGBTIQ, especially youth and young adults. And I'm just really happy to be here with everyone today.
DJ, if you'd like to go next.
Sure, thanks. So just to lead off, I am in a rural part of Oklahoma right now, and so my internet might be a little spotty. So if you just catch me smiling at the screen, give me a nudge. Probably means that my rural internet has slowed down a bit. So my name is DJ McMullen, and I am an assistant professor in health education and promotion at Oklahoma State University. And I'm a health services researcher. I focus on the healthcare system. And as part of my foci, I do look at healthcare utilization among transgender individuals and the intersection between different identities like transgender identity and disability.
My name is Andrew Robler. I am a healthcare simulation educator, and I currently work as the director of clinical simulation for the new College of Medicine at the University of Houston. I know Frankie and Dr. Pittman from my time working for the Texas A&M Health Science Center and the simulation program there. So in clinical simulation, I oversee the Center for Clinical Arts, Skills, and Experiential Learning in the College of Medicine, and work with faculty to develop simulated scenarios for medical students in particular, but students of all different health disciplines to practice healthcare skills, especially patient interaction and communication and things like that. And one of my big passions and focus in that is LGBT healthcare simulations and how we integrate sexuality and gender and all of those things into the training of our medical students. Oh, and my pronouns are he, him. Sorry, I forgot about that part.
I forgot mine too. Any pronoun or they, them.
We may have lost our host, I wonder.
I think so. I mean, Allison, do you want to just talk to us about disparities? We got this. Gonna take over.
Frankie, if you're on and you want to comment in chat, we'll keep going. We can do this. One of the things that Frankie wanted us to do is just do a quick overview of health disparities. And so I have a few quick graphics that I wanted to share with folks. And so I'm going to get those started if that's okay. Let's see. So like I mentioned, hopefully you guys can see this. If not, let me know. This has been a big passion of mine ever since I was a pediatric nurse. I was a bedside nurse for 13 years and noticed a lot of health disparities in youth who are LGBTIQ and a lot of interest, the I part intersects. We saw a lot because the places I worked were big endocrine centers, and there were just a lot of health disparities and a lot of struggling. And that was kind of the start of my passion. And I'm currently on a team of interprofessional faculty and staff who were trying to put together a health curriculum specific for all of the disciplines in the Health Science Center at Texas A&M to improve our education on these issues. So let's get to the real talk first. This is perhaps the most difficult part for me to talk about because it seems like we're focusing on some negative things, but we want to be real first, and then we're going to talk about some of the movement forward that we see. First of all, I want to focus on some of the psychosocial disparities that we see in LGBTIQ folks. We know that there's discrimination that's experienced in everyday life, just walking down the street, and that LGBTIQ folks are more likely to experience rejection from family. Unfortunately, a lot of folks report discrimination in healthcare settings from everywhere from staff to their providers and other patients in the waiting room. This leads to what we call minority stress, which is defined as sort of the additional stressors that any minority, but including LGBT folks, experience when what's related to the discrimination and the stigma that is associated with being a minority sexual orientation or gender identity. And so all of these things can sort of lead to, poor mental health, anxiety, depression, detrimental coping mechanisms like substance use. And on the right side of this slide, it just shows some statistics about percent of sexual majority versus sexual minority use of substances as a coping mechanism. Along with all the other things we do when we're trying to escape difficult situations. Youth and young adults who are LGBT are more likely to be homeless. Oftentimes they're rejected by their family and don't have a place to live. And even unfortunately engage in risky sexual situations like sex in order to survive, in order to get food, income, housing, things like that. There's also physical health disparities that we know from what research shows us. LGBT folks often have lack of access to healthcare, sometimes because of hesitation to seek healthcare, sometimes because of geography, sometimes because of not having health insurance. And so we are seeing some new things come out that say that this population is more likely to rate their health as poor. And it may be that because of the discrimination that we experience when seeking health care, we are less likely to go to seek medical care when we know that something's wrong or we feel like something's wrong. And so we're even seeing some new reports that say that both men and women, all genders who are part of the LGBT population have increased rates of cancer, heart disease, and other chronic conditions. And they speculate that this may be because they don't seek care and do the routine screenings because they are hesitant or afraid to seek medical care because of discrimination, financial issues, and other things like that. We also want to talk about other contributing factors. We don't want to ignore what we call intersectionality, which is when our gender and our sexuality also sort of intersect with other aspects of social and emotional health that affect our ability to be healthy. And those are reflected, there's lots and lots more than this, but these are just some examples of a lot of the different factors that intersect that affect our health. We also know that there's not good education among healthcare workers in our country. The average medical school only has about 4 hours of content on LGBTQ health, and other disciplines like nursing, pharmacy, dentistry are not much better. And we don't have a lot of research on health in this population. We know that health benefits can be very restrictive for LGBTQ folks. We need more role models that are positive health role models. There's not a lot of awareness of the disparities in the general population. And then we have the added recent contributing factor of COVID-19, which isolates us even further. We're afraid to seek healthcare because who wants to be in a hospital emergency room? Who wants to be in their doctor's office when there's increased risk of getting a virus? And so there's a lot of information that's telling us that LGBT folks, particularly the uninsured, are even more isolated from getting healthcare because of the virus. Okay, let's talk about some forward-thinking, positive things that we know about LGBTQ health. And the first one that I want to talk about is resilience. There's a lot of references that you'll be able to see in the slides that really talk about who are the outliers. A lot of times all we hear about LGBTQ health is the negative things, HIV and AIDS and all the stuff that's shocking in the media. But there are so many folks that, despite all of the disparities and the obstacles, are able to overcome and have very healthy, happy lives and be healthy. And some of the things that have been shown in research to be helpful are listed here. And one of the things I want to key in on is family support. I know that there are a lot of folks who do not have support from their families because of their gender identity and their sexuality. But family has a very broad definition for a lot of us. And so a lot of times you have a new family and very close people in your community and friends, extended family that are a support for you during difficult times. A lot of times focusing on strengths and a lot of health education, living in a community where there are resources. These are all things that both intrinsic, things that are inside you, like the way you think, and also things that are in our environment that help us to be resilient. This is just a wonderful quote that I really like that sort of defines what we are talking about when we talk about resilience, that, like tiny seeds to push through tough ground and become mighty trees. We do have reserves within us of an unimaginable strength, and we are resilient. When we look at what we can do as individuals or as a community to improve health for LGBTIQ folks, we always encourage people to start by examining our own views. What kind of thoughts or biases or strong emotions or feelings do we bring to the table when we think and have discussions about health? Look around the community where you live and look at what options are available, what kind of resources are available within the community where you are now, or maybe where, if you're a student and you plan on moving when you graduate, when you're looking for places to work and live, what kind of resources are available for LGBTQ folks? Educating yourself, obviously, on health issues, like being here for this webinar, and asking about, this is maybe particular to those who are seeking health careers, but when you're looking for a place to further your education, what kind of curriculum or content do they have related to some of the health issues in this population? One of the things I want to highlight is how things are getting better. We are seeing a lot of increased awareness. Even in mass media, we're seeing more hits on articles that focus on health issues for our population, and a lot more efforts to improve education across the board, including for healthcare providers. There's more opportunities for research. There's more funding specifically for this. And a lot of communities, like the Pride Community Center here, is developing and already has some on their website, LGBTQ friendly providers that are in the community. Before, this was just kind of word of mouth amongst the community members. And now people are developing lists that are available for people when they want to know who is a provider that I can be comfortable being out to and has good resources and is well educated on my health issues. One of the biggest things for me as a nurse and as an educator is actually involves Andrew, who's with us today. Gosh, Andrew, I don't know how many years ago it was that you headed the Med Pride, not experiment, but simulation in the CLRC on the Health Science Center campus, where Med Pride, an organization within the College of Medicine, had a waiting room, like you're walking into your healthcare provider, a waiting room that was LGBTQ friendly, and a waiting room that was the way most of them are now, which are not LGBTQ friendly. And there's a big awareness and a push to create an environment that is welcoming and friendly to all. And it's things that are just as simple as having, signage. And when you fill out the forms, we've all experienced this. When you fill out your intake forms, are there options there that make me feel like I'm part of the patient population and things that apply to me? Electronic health records and displaying non-discrimination policies, having something as simple as educational brochures and magazines that are LGBT friendly in the waiting room and in the doctor's office. There's a big push just to improve the environment that we provide healthcare in. There's also a lot of new treatment guidelines that are being put out that specifically are targeted to help the LGBTQ population, like CDC treatment guidelines. SAMHSA has mental health guidelines specifically to help this population. And of course, WPATH and the Independent Treatment Center have specific guidelines for transgender folks that are really helpful. And this last slide is just, again, this is just an overview, but if you want any information in addition to what was listed here, please feel free to ask us any questions. And also, I think Frankie's going to sort of provide these slides for you. These are some great links to both local and national resources that can help you learn a little bit more about some of the disparities and some of the educational efforts towards LGBTQ health. That's all I have. Oh no, there we go.
Great. I'm gonna pop back on. Allison, that was awesome.
Thank you. Did we get Frankie back?
Can y'all hear me? Can you hear me?
Yay!
Yeah.
Oh, I'm back.
You're back.
We love that. Thank you so much, Allison. That was really great. So now we wanted to take the time to go over some of our pre-submitted questions. I think the first one we wanted to ask is, can you tell us about a time that was an affirming health experience for you?
So, are we going in a particular order, Frankie?
Nope, you can feel free to answer.
So my short answer is no, but I'm going to give a little bit of background why. So, and I should have mentioned this when we were introducing ourselves. On top of being a health services researcher, I have a chronic illness and am like what Brianne Benes calls dynamically disabled. And so most of my interactions with the healthcare system are in that context. Also being perceived as female in that context also tends to generate some more negative experiences. So that's my long answer to the short answer of no, not a whole lot of affirmation in the healthcare system for me. It probably doesn't help that I study it.
So I recently moved to Houston from College Station and had the opportunity to find a new doctor here in Houston because I had changed areas, and there's actually a really wonderful LGBTQ focused health clinic, community clinic here called Legacy that does a lot of specializes in the LGBT community, and in particular in transgender healthcare and other issues like that. And they focus a lot on youth and homeless youth, and it's just a really great organization. And so that was the first time that I had ever gone to a clinic feeling like I don't know, the population that the clinic expected to walk through the door, we'll put it that way. And I think that was really cool. And that was an experience that I've never had before in any medical setting whatsoever. So I think that was a really affirming experience for me.
I would just add, this is going to show my age. When I went to nursing school at University of Texas in Austin in the 90s. And at that time, and it still is somewhat of a place where there's a lot of resources for homeless folks, especially homeless youth. And this is much less so now, really, unfortunately, because of some social changes. But there were a lot of homeless youth that hung out on the drag in Austin on Guadalupe Street. And a lot of them had a lot of health issues, and a lot of them were LGBT. And so we, as a nursing student, we did a lot of work with a lot of different community organizations. And coming from a community that I grew up in that was very conservative and not welcoming, this was so, and again, this was 25 years ago, to be in an environment where care was provided, no questions asked, and people were treated with respect, and youth who did not have health insurance, who did not have income, were provided healthcare with dignity and given the resources they needed, not just healthcare resources, but social resources, a place to live and food. That really started me off on a journey where I saw the right way to do things when people are at a disadvantage in terms of health and society.
Thank you all. So our next question is, can you tell us about a negative health experience or health experiences? We'll let y'all share as many as you're comfortable with. And again, if someone wants to pass, that's totally an option.
Sure, I'll go ahead and kick it off. I've got plenty. So most of my negative experiences kind of center around symptom minimization. So with my chronic disease, there's a fair amount of chronic pain that goes along with it. And just kind of, we see this also bearing true in research and also anecdotally, that pain in people who are perceived, who identify as female or are perceived as female, tends to be really minimized. And so I have a lot of interactions with healthcare providers where I say, like, hey, I'm in a lot of pain, and they're like, you should just take some Tylenol. I'm like, no, I don't think you really understand what I mean when I say I'm in a lot of pain. And it's very hard to get the attention of health providers when you're talking about pain. There was a really specific instance that I was thinking of where, with my neurological issues, I have a lot of like movement at night that I wasn't aware of. And so I was talking to the neurologist, and they asked, do you move around a lot at night? And my partner said, oh, let me tell you, like, they're moving all over the place. So, okay, we're gonna send you to a sleep doctor. Maybe you can do a sleep study. And I said, well, that sounds awesome. So there we go. We're talking to the sleep doc. And the sleep doc asks a few basic questions and then says, have you ever experienced trauma? And I kind of stopped and, like, as somebody in, like, turn of the century United States with multiple marginalized personality, like, identities, how could I not have experienced trauma? It was kind of an interesting question to me. And so I kind of went, Yeah, like who hasn't? And the doc said, there you go, off to a psychologist. You don't have any other issues. And that was it. That was the end of the sleep consult. And so that's the kind of minimizing that just, our negative experiences in the healthcare system. But I do have, because I know that we do want to end on a positive note, so don't worry, when we come to suggestions, I have suggestions on how to interact with the healthcare system.
Thank you for sharing that.
I'll go next. So I want to start by saying that I always feel a little silly when I talk about my quote unquote negative experiences because I am identified as male. I'm assigned male pronouns just very naturally, and so I have a much better experience than pretty much anyone who does not identify as male in the healthcare experience in the healthcare industry here in the U.S. So I just want to acknowledge that up front because I actually don't know that I can think of a time when my symptoms have been minimized. So there's definitely, this is me talking from a position of privilege for sure. The one experience that stands out to me that was probably one of the most jarring healthcare experiences was when I was going in for, I was having a little problem in my neck and I gone in to see a doc that specialized in ear, nose, throat kind of stuff. And he started asking me a series of questions and eventually got to whether I was sexually active, and then wanted to know whether or not there was any risk of me contracting HIV, which, not necessarily the most out there in terms of he was trying to think through what this could be because we couldn't figure out what it was. But his mind jumped to HIV, I think in large part because of a t-shirt that I was wearing that day. That happened to have a rainbow on it, and so I trying to be a good patient, kind of thought about it, and I was like, okay, I mean, I am sexually active, but I have protected, safer sex, but there's still a risk technically, and so I said, yeah, I think it's very small, but there is theoretically this risk, and he, much like what Dr. McMahon just said, was kind of like, oh, okay, well, let's get an HIV test, and it was just kind of this, it's really hard and it feels really silly to explain it because to someone who wasn't there in the room, it sounds like, oh, he was just being thorough, yada, da, da, da. But that's not what it felt like in the moment. What it felt like in the moment was that he had made some assumptions about me, that he had made some assumptions that I was involved in sex with other men, that I was at risk for HIV, and since he couldn't figure out what else this could be, that clearly was something that he was thinking just because. And then, oh yeah, and then I forgot. He proceeded to give me a talk about how to protect myself and the importance of being careful when I have sex, et cetera, et cetera, et cetera. Yeah, that's probably the most explicit. But I've had constant experiences in healthcare clinics of all kinds, not just doctors' offices, but dentist offices. You walk in and you see, Focus on the Family magazine on the coffee table, or you walk in and you see, all of these like pictures of heterosexual couples and kids, and they're you fill out a form that doesn't have any genders other than male and female, and that wants to know if you're male then who your wife is, and if you're female then who your husband is, and kind of all of these assumptions that are just kind of like dog whistles, essentially, like this like signal that's like, hey, we don't really know how to deal with you. And that leads to a lot of anxiety, which is something that I struggle with already, that I take medication for. And it means that a lot of times it's very nerve-wracking for me to go to a doctor for the first time or even for the 10th time. So that's the majority of my healthcare experiences, although, like I said, recently that started to change. So that's been cool.
Glad to hear things are starting to change.
I think the main thing that I could add to answer this question is really from an ally point of view, because I am cisgender and straight, and but I have been a nurse for young people for a very long time, and I've seen, even in the last few years, when I first became a nurse and noticed discrimination in terms of care to young people. I was new, and this was someone who was my boss or that I took orders from, and I didn't speak up. I just kept my mouth shut. But lately, even I think after the first couple of years as a bedside nurse, you get this tough coat of, go ahead and tell me I can't do something. And so I got my voice back. And so when we would have a patient in the ICU, for example, that had attempted suicide and looked different, I gave report to a nurse one time, and she sort of looked into the patient's room and came out and said, "So he's a tranny," and like this look of judgment on her face. And I just, what is that? Tell me what that word means to you. And sort of went off and sort of explained, why is that coming out of you with this sort of judgment voice? And I didn't really, I had to really sort of try to focus on patient care, even though this was a nurse that was much older than me and in a position of authority over me. I've learned to sort of find my voice and correct when people use terminology and tone of voice and communication issues that really isolate people. So just knowing that, sometimes it may just go over people's head in one ear and out the other, but there are a lot of people out there that are brave enough to speak up, and we're trying to teach and I see a big difference in the nursing students that I taught 14 years ago when I started versus now, in terms of the assertiveness and the ability to speak out on behalf of patients that are being discriminated against.
Wow. So our last pre-written question, so folks are interested and have questions for the panelists, please submit them either here in the webinar or on Facebook Live. But our last one is, what tips do you have for allies? And that can be either, let's start with tips for people who aren't medical practitioners. How do we support those? How do allies support folks?
So one of the things that I think is really important and helpful when it comes to helping anyone navigate the healthcare system, regardless of identity, self-advocacy is hard in a medical setting. The system is set up to kind of shuttle you through it very quickly because time is money, and that means that you often are faced with people that mean well but are very, very crunched for time, and that can sometimes come across as not being interested in really listening or talking to you, and that, especially if you're someone like me that deals with anxiety or something like that, that can be really, really challenging, and it's really hard to kind of feel like you're constantly in the hot seat. So in terms of allyship and support for people that are struggling with that, one of the things that I've seen done with a lot of success is, if you have a friend that's going to the doctor and their doc isn't listening to them, or whatever, offer to go with them, even if it's just someone to sit in the waiting room with when they're confronted by and this is not me knocking Christianity, we can talk more about the reason that I'm going to use this example, but confronted with all of the Texas crosses on the wall of the waiting room, and the focus on the family magazine, and the pictures of the heterosexual couple, and all of that kind of stuff. But even going so far as to sit in on their appointment with them if they invite you to do that, sometimes having another person there to ask questions and to listen critically can be really valuable. And because we're not the one in the hot seat as allies for those people that are going through that, sometimes we can ask questions that they don't feel comfortable asking because we're there to support them, and that's kind of our job. Whereas their job is to get better and to feel better, and not always, do they have the energy to advocate for themselves. And it sucks that they have to even be put in a position where they have to advocate for themselves, because the physician or the nurse or whoever's seeing them should be advocating for them from the get-go. So that's one very concrete example of, I think, something that you can do if you know someone that is struggling with that, or if you're someone that's struggling with that, then asking a buddy, asking a friend or a family member to go with you can be really helpful.
That's fantastic, because that was exactly my suggestion, Andrew. And so I recommend either being or bringing an accountability buddy. And just exactly like Andrew said, like, this is somebody who is going to help you, almost like a healthcare doula, like help you navigate the system, help you reframe, bear witness to, what's occurring around you, and kind of help guide you through the process. So I second everything that Andrew said. That's exactly what I would recommend, with the caveat that knowing that not all of us have somebody in our lives who can function as an accountability buddy or a healthcare doula. So it is doubly difficult if you are in an isolated situation, and I get that. So yeah.
I love that, the idea of a accountability doula. That's just fantastic. I love that term. That made me giggle. I would love to have if everyone could have a DJ or an Andrew to go with them to their healthcare appointments, that would be fantastic. And that person can be someone on the phone. It can be someone that you text back and forth with if they're not able to be there with you personally. I would also maybe just add, to be an ally a lot of times means, when we start talking to healthcare students, we always start with communication, because one of the biggest barriers that we know for people who don't come from a place where they have interacted much with LGBTQ folks is they're scared of saying the wrong thing and of communicating, even using the wrong pronouns or asking about pronouns wrong or offending someone in some way. And so, I think the conversation a lot of times needs to start with understanding terminology and communication. And I know from people I've talked to, some of whom are here today as attendees, have just shared their frustration with constantly having to define who they are, how they identify, what this term means. And I know that gets tedious. So one of the things that we're trying to do, especially with healthcare providers and staff, is to really make them more aware of appropriate communication, because as we learn throughout healthcare, that's the barrier to a lot of effective health provision and patient safety, and feeling safe in healthcare is just by the way we communicate.
I'm going to add one more thing to tag on to that, because I think I'm big on like action steps when it comes to that. One of the things that you can do is ask your provider, especially if you're in the Bryan College Station area, ask your provider if they and their staff receive training or seek out training for LGBTQ health in particular. There is no great directory of providers that are LGBTQ friendly. The Gay and Lesbian Medical Association, the GLMA, keeps a provider directory, which I just searched for the Bryan College Station area, when there are 2 more people than there were on there a couple of years ago. And that means there's a grand total of 2, because a couple of years ago there were 0. And so that's something that providers have to opt into. And a lot of times providers, especially cisgender straight providers, don't think about that, and they don't think about the kind of what they could do to better support that community, our community. And so whether you are a member of the LGBTQ plus community or whether you are an ally, that's something that you can absolutely do. Don't be afraid. I tell patients this all the time. Don't be afraid to interview your doctors. Don't be afraid to ask them questions. They are part of your team. They are there to help you, and don't be afraid to ask them questions. I say don't be afraid. Sometimes they can be very difficult to ask questions of, so I want to explain that very clearly. Like sometimes it's okay to be nervous, but especially if you're in a position of confidence and a position of energy that you have within you, to be emotional energy to have that conversation, especially as a straight ally, or a cis ally, that is a great way to take action to ensure that that communication that Dr. Pittman was talking about starts to change.
Yeah, I'd just love to add listening to folks. I think as someone who identifies as LGBTQ, there were a lot of experiences that I just like felt very like in a bubble, like, oh, it was me, like that wasn't what happened. And then when you start talking to other folks, it's surprising how similar experiences are. So trust your friends and just listen and be there if you can't do anything else. So we have a question from the audience, and that is, what can doctors do to make the LGBT community feel safer?
I'm looking at Andrew to see if he has worked.
I was looking at Dr. McMahon because she said she had a whole list of suggestions.
Oh, well, then let's
so
let her,
I want to let her go first because
I
feel like she's got a lot of experience here, and I think that's really valuable.
I don't know if I can say that. Like, oh gosh, it's a really tough one. And I think that coming from the vantage point of looking at how the healthcare system operates, I'm almost overwhelmed to try and think like, okay, what can doctors do to to make a safe place for LGBTQ plus people when the whole system has some pretty serious flaws right now. So it's hard to kind of wrap your head around like, what is this, what are some little things that we can do to make a difference. I would say that what I've seen so far in the work that I've done is a lot of the foci on health among LGBTQ plus people is really centered on kind of like what Andrew brought up. It's centered around HIV, and Allison mentioned that as well. It's centered on somewhat negative or almost titillating for people, like you're transgender, like let's talk about whether or not you've transitioned or stuff like that, and not really a focus on just like basic health. Like our identities are more than, our health is kind of broader than just that slice of our identity. So I would say that for physicians, if you can be just treat people as when they walk into your office, as a person who's walking into your office looking to be healthy and looking for healthcare, and meet them where they are and be open and be honest, and also maybe be a little vulnerable and be authentic, that'll go a long way. I personally don't like the idea of decorating offices with religious stuff. But I think, like Andrew said, like that's a totally different topic that maybe we shouldn't delve into like right now. Like I feel more comfortable with an office that's kind of not, doesn't seem to have a particular political persuasion or particular religious persuasion, that seems to be focused mostly on healthcare. But I guess like if I were to talk to a physician and a physician asks me like, well, what can I do? I would say, well, meet people where they are, be authentic, be a little vulnerable, listen, and don't be afraid to be wrong. But I would give that advice to any physician who's interacting with any person.
I think that's excellent advice. I think in terms of LGBT issues, the first one is seek out education. Like Dr. Pittman said, most medical schools and nursing schools and pharmacy schools and dentistry schools, if they have any education on LGBTQ plus issues in their curriculum, it's usually a max of like 4 hours. It's one afternoon or one set of readings or something like that over the course of 4 years. And part of that is a factor of how much information students need to learn in clinical education. But part of that is also just the fact that it's not a priority for a lot of schools, because the people that are in charge are cisgender and heterosexual, and they see themselves as the norm. And that's the key that I was going to kind of piggyback on what Dr. McMahon was saying, is that really what it comes down to is trying to work to not see yourself and the people that look and behave like you as the standard. Because a lot of times when we look at office design or form construction for intake, right, all of these things, people write from their perspective. They write, well, how would I need to fill out this form? And that is often completely ineffectual, not just for the LGBTQ plus community, but for a lot of communities. And so it's really about education and exposure and looking for opportunities to interact with people that can teach you and can help you grow. And I talk with medical students all the time who tell me like, oh my gosh, how am I going to do this on top of everything else that I'm learning? Or on current practitioners that are like, I barely have time to read, the research on, prescription drugs. How am I supposed to do this? And at the end of the day, my answer is, I'm not sure, but you're the one that chose this career. And if you're serious about taking care of your patients, then you will make the time to do this. You will find the time to do this. And it's going to be hard, and it's going to be challenging, and you're going to be imperfect at it, and you're going to make mistakes, and you're going to upset people. But that's part of relationship. That's part of the way that we build and maintain relationships as human beings, and especially as care providers. So I think that, to piggyback on the really excellent stuff that Dr. McMahon said, that's really what's at the core for me.
The only thing that I would add, and I'm seeing some great stuff in chat from attendees that are in health careers, is to sort of, we talked earlier about asking when you're looking for places that you're going to advance your education or where you're applying, to ask about their level of LGBTQ health content. The same goes for any it may be any provider that went to school 20 years ago or more probably got 0. And so but there's no reason why a provider, when you think about the percentage, 1 in 10, 2 in 10 of our general population, depending on where you live and geography and stuff, if we ignore the differentness of LGBTQ folks and don't educate ourselves on their specific health issues, that's a significant part of our population that we're not focusing on their needs. And so even if a provider went to school and didn't get a lot of content on these specific health issues, we've have a few links in chat about continuing education opportunities where anyone can get a lot of continuing education credits, even get an advanced health certificate. And so a lot of this stuff is free. And especially right now, like I went to Louisville to get the certificate and had to pay for airfare and all that. And now they have it online on Zoom for free because of COVID. So right now, as we're speaking, a lot of this is online and free. And you get this wonderful educational opportunity that you would probably have to travel to do before. So increasing awareness on those things for providers and making sure that they take advantage of those opportunities can really make them better. And I so agree with what Andrew is saying about the different, everyone comes to the table with relating how they respond in healthcare settings or any other setting. And there's so much that can be said by addressing those those even intrinsic biases that we bring to the table, and how it's the climate right now. That's the only thing I'm going to say about it, is just the otherness of the stuff that people that are like me and the others. We've got to stop doing that in societal constructs, especially in healthcare. Okay, that's it.
Thank you all. I'd just like to add, as someone who's gone through the healthcare system and is a total layperson, so again, not a medical practitioner, but be careful with shaming. Patients will pick up on that, and it may inform how they respond to you, and you can't give the best possible care if your patient is lying to you because they're afraid of your judgment. And yeah, with that, we are getting close to time, so I'm going to ask panelists for final thoughts, and then the center, and then I will close this out.
I'll go ahead and jump in. I think that, I don't know, there's so much more to this conversation than can be covered in 50 minutes. And so I hope that if nothing else, that you leave this conversation hungry to learn more. Dr. Pittman put some really great links in the chat here on Zoom for the LGBTQ Health Resource Center, Education Center, as well as from University of Louisville that has this course that she was talking about. Seek out those resources. I know that there are great resources at A&M for checking out books and films and other resources that can point you in the right direction. And really, you just can't stop learning. You have to keep pushing and you have to keep searching, and that can feel really tiring and exhausting. But when you stop and think about the reason that you're doing it, which is to make sure that people feel welcome and they feel included and they feel safe to confide in people that are helping to support their health, which is so crucial to life, to continued life on this planet. It's worth the extra effort. It's worth the fatigue that comes with kind of the research and the learning. So hang in there, and it is possible to navigate this system for those that are struggling. I promise it is. They don't make it easy, but it is possible.
I would only want to close with thinking again about those resources, aspects, factors of resilience. And one of the ones that we didn't touch on that really stands out to me is empowering others in the community. And so, not being afraid to speak out and talk about health issues, talk about sex, sexuality, and sexual behavior, and health issues related to that. I think looking at the things that make us stronger and resilient, and being on that, it is so hard, especially, I don't know about y'all, but I go down rabbit holes of social media that I end up being very discouraged by the opinions that people put out there. So I restrict my social media diet, and I focus on being on the team that moves things forward in a positive way and empowers others and is hopeful. And that can be anyone within our community. I think it gets tiring sometimes, and we have to take care of ourselves. But I think focusing on those aspects that empower and provide resilience in other people is really important, something that we should not forget to do.
Okay, I'm trying to jump in with my wrapping up statement, but I've been looking at chat questions, and then I have there's a Q&A question over here too. So there's lots of stuff going on, and Luke's philosophical question was excellent and took a lot of my brain power for a few minutes there. But I would say, both Andrew and Allison mentioned, we have to keep moving forward. You can navigate the system. You may have to put some time and effort, unfortunately, into finding the best way to navigate the system for you based on your needs and based on your characteristics. But it is definitely possible. Sometimes you have to be pretty I hate to use the cliche phrase, think outside of the box, but sometimes you have to come up with ways to make sure that you're getting what you need out of the system. The system isn't damaging you more than, that isn't causing damage that wasn't there before you went to the doctor's office. So as an example, I have, like Andrew, I have a lot of anxiety. I'm on the anxiety depression spectrum. And one thing that triggers me is my weight. And I just don't get weighed when I go to the doctor. That's one of the things that I've kind of learned in my interactions with the healthcare system that's unique to me. And so, and it does kind of rattle people. Like I'll walk in and they'll say, step on the scale. And I'm like, no, I'm good, thanks. And they're like, wow, but we need your weight. I'm like, well, when you need it for like a medication or something, then we can talk. But this is going to ruin my whole week. And so I'm not stepping on that scale. And so you can do those things, and you can, I hate to put the onus on other people, because really the onus is on the healthcare system. But unfortunately, we're in a situation where we are right now, where you're going to have to empower yourself and reach out to people who can empower you and help you navigate and work through the system to get your needs met and to get what you need. But it is possible, and it is especially possible if we focus on education, and if we focus on community, and if we focus on resilience, like Allison mentioned. And it was a lot of fun chatting with everybody.
Awesome. All right. Well, thank you all so much for participating. This has been really informative. If you liked what we did here today, we will be back again in November, November 10th. We will have our Pride Live drag, which will be super exciting. And you can follow us on social media. Our handle is at LGBTQ FAMU. Thanks, and Gegum.